further, we hypothesized that these effects of XIGRIS may be mediated by actions on inflammatory and the apoptotic pathway. To test our hypothesis, we used a well-validated model of cerulin-induced acute pancreatitis rat model, where we administered activated protein C at 500 micrograms per kilogram body weight. We essentially tested two protocols, one the early intervention protocol, and secondly the late intervention protocol. The early intervention protocol, or the mechanistic protocol, had essentially 5 different groups. The first group was the control, then we have the cerulin. Cerulin plus activated protein C, and we have the vehicle and the activated protein C as well. Now, we were looking at the first 3 groups. As you can see, cerulin was administered for the first 6 hours, but activated protein C was administered the first hour. All the animals were sacrificed at 24 hours. Now, this is the late intervention protocol, essentially similar, but here the activated protein C was administered at 24 hours, and animals were sacrificed at 48 hours. Now, for the purpose of this presentation, we are looking into the biochemical markers, the hematological and the coagulation profile, the NFKB pathway, and the apoptotic pathway. Just to represent the early intervention protocol here is represented as a 24-hour period when these animals were sacrificed, and 48-hour being the period when they. So the 48-hour being representing the late intervention protocol. In the acute pancreatitis group, there was an increased level of amylase and a significant drop in the treatment group. This was reflected in the 48-hour as well. Similarly, the lipase group, in the acute pancreatitis group, there was a higher level of lipase for the treatment group showing a significant drop. Again, both in the early and the late intervention protocol.
You use the pardon?
Anyway. Now, as we all know that activated protein C is a coagulation modifying medication, and thus we found that looking at the peak prothrombin time and the prothrombin time, essentially they're all similar in all the groups, both in the early and the late intervention group. Now, this methodological profiling, hematocrit was essentially similar in all the 4 groups, both in the early and the late intervention as well. Now, this is moving on to the histology of the pancreas. As you can know, this is the acute pancreatitis group in both the early and the late intervention protocol. There was a loss of architecture with edema and necrosis of the pancreas. But in the late in the treatment groups, there was the normal architecture was empty, but no evidence of hemorrhage was also not seen, or rather there was no hemorrhagic evidence. Moving on to the NFKB-P65 or the NFKB pathway. In the acute pancreatitis group, there were increased bands, which on densitometric analysis we found that there was significant drop in the treatment groups. This was found in both the early and the late intervention group. There was a reversal of these levels with the treatment group showing a higher level in the IKB alpha group, both in the early and the late intervention protocols. Moving on to the apoptosis. Bax protein was found to be increased in the treatment, in the acute pancreatitis group, whereas there was significant drop in the treatment group, both in the early and the late intervention protocols. And the anti-apoptotic BCL2, again there was a reversal of these results with the treatment group showing a higher level of protein, BCL2 levels, both in the early and the late intervention protocols. Moving on to quantitative assessment using tunnel or apoptosis. There was increased amount of apoptosis in the acute pancreatitis group with a significant drop in the treatment group, both in the early and the late intervention protocol. To conclude, this study demonstrates that acute protein C does not lead to pancreatic hemorrhage or cerulein-induced acute pancreatitis. Activated protein C ameliorates the effect of cerulein-induced acute pancreatitis through the NFKB and the apoptotic pathways. Based on these findings and the results of other groups, a phase 2 study of the role of XIGRIS early in severe acute pancreatitis is now underway.
Some of us who belong in the two, please excuse me. This model has been around for a long, long time, and in fact, ATTENUATES was used on this model and was brought into clinical practice on the back of that experimental work. And really, as I understand it, I'm no longer involved in it. We don't bother with being present to be ineffective. But I think to convince this audience, you've got to comment on the quality, the translation aspect of your model. I mean, it's good science, but that is a key factor in it.
It's a good point, but it's not only our group. Our group itself have done two models. We looked at the LRG model as well as the cerulin model. Various other groups around the world also have looked into different models, and all of them have similar findings. And that's the reason why we decided on moving on to the trial, because the evidence shows that there is some effect.
Question from the audience. You're convinced?
Yeah. My suggestion is you go out to drink your 10 or 20 pints that you should take to activate a protein secret.
Well,
where is it going clinically? Your patients come in the day after severe alcoholic pancreatitis. They end up in ICU. This will have no road.
Speak from personal experience here.
I mean, this is slightly different. This is the basic science part of things, but you're looking at the clinical aspect of things.
Yes.
And the clinical aspect, the phase 2 study is looking at patients who are admitted within 24 hours, or rather, who are admitted into hospital, and we start off treatment within 24 hours. And the criteria for that is the fact that you have an APOPTOTIC around 15 and above. Because acute protein C is actually used now in sepsis, but it's only 45 and above. So we are looking at very severe patients that we intend to give, and we intend to give it early on in the acute pancreatitis phase.
But in fact, not all pancreatitis is
required. Exactly. So we're only looking at very high level.
Sorry. Yeah, please. Yeah.
I offer your conclusion substantiated by the results, because you just showed that the ATC modulated the expression levels and apoptotic related proteins and other. No data indicate that these are causative in this model.
Sorry, you repeat the last sentence?
No data indicate that these pathways are causative. Cause and effect. You just showed an effect on ATC can affect so many different pathways.
Yes. Well, let's put it this way. The NFK pathway is the beginning stages of an inflammatory action, and of course, being somewhere in the end. We have looked at the lower parts or going down to the cascade. We have looked into that, but not in this one. 1, 2. The other thing is that in the 7 minutes that I have been given, it wasn't possible for me to put all the results in there. But there are more tests that we have actually done.
And I'm sure you'd be happy to share it.
Oh yeah, sure.
Yeah, one last time.
I think it's a nice study, but in large part intuitive, because ATC works through NFKB, which drives inflammation. But it's nice to show that in an animal model. I'm intrigued in terms of your clinical study, how have you designed this with respect to timing and exclusion of patients if they come in with altered existing coagulation profiles, as many do.
Well, that step from the from the bleeding signs to the clinical straight did not happen straight away. There is another study that Dr. mentioned this because of the time constraints. We've actually done levels of protein C to ensure that there is a drop in the severe epidemic pancreatitis phase. So yes, there is a drop, and thus we feel that it will be. Now coming to the other part where the risk of bleeding. Yes, we know already that the PROWESS trial there is a very low percentage of bleeding. But we're hoping that the results will come out once these trials.
Okay, thank you very much. I'd like to thank you all for